Just be careful what you say now, Anand.
Can you repeat that that once more? Like how many times are you putting that cord back in and all that? Yes, sir.
Okay. Let's get Abby in. Are you with us, Abby? Can we hear you, Abby?
Good evening, sir. Sorry for being late, sir.
That's okay. We were waiting for you.
I'm so sorry, sir, for being late.
Because this session is for you once we get started, okay?
Yes, sir. Yes, sir.
We were talking about when doing a crown preparation, how many impressions to take, when to make your temporary, and how many times you put the retraction cord in. What I'm saying is that ideally you prepare the tooth down to the crown, down to the gingiva. You then use an electrosurgery to open the sulcus. You then lengthen the crown preparation. And when you have completed the crown preparation the best you can, you then check it 3 times. You retract the cheek and the tongue, dry it, have a good look. Then you do it again. Have another look, and then you do it again, have another look. So that if you're satisfied, you then put the retraction cord in. You get ready to take your temporary crown, make your temporary crown. You put the acrylic into the alginate impression you took originally. You then take the cord out and you put the alginate in the mouth. You then take the alginate out and you've got your temporary crown roughly made. You then put the cord in and you then put your, take the cord out and take your first silicone impression. While your assistant is holding the impression in the mouth, you're trimming the temporary crown. Okay, now, Abby, I know we're assuming you have an assistant. Okay, so if you don't do that, when you do have an assistant, that's what you do. You then take the impression out and you check it and you put the cord back in again. You then take another silicone impression and you then finish your temporary crown. Okay. Ideally then, and you may take a third impression. Okay. You then have the impressions poured up. And the next day, if you were pouring them up in your own clinic, you would then check them and decide whether they're high enough quality or not. And if they're not, you get the patient back again and do what you have to do, either to change the preparation or to take better impressions. Then ideally, you send the models or the impressions off to the technician and they pour them up and dye trim them to within 1.5 millimeters of the margin. And then they send them back to you for you to dye trim. And then you dye trim them and you have another opportunity of deciding whether the quality is good enough. This is if you really want to improve your crown preparations. Okay. Any questions, Anand? Siley, can you talk to us?
Yes,
You routinely use retraction cord.
yes, most of the times, 90% of the times.
Okay. And how often do you use electrosurgery?
Not that often.
For the reason?
I've had this block in my mind that it's done only when the crown height is less. So, and also I fear the patients will not agree. I don't know.
They are going to be sore afterwards.
Okay.
But I think that after a dental appointment, they expect to be sore. I couldn't imagine doing a crown preparation without having done electrosurgery. You have to have them numb, buccally and lingually. So they need a long buccal infiltration as well as a mandibular block, and they need a buccal infiltration in the upper and a palatal numbing. I mean, I think that you need to have the crowns fitting down on the teeth as much as possible. Okay.
What do you think about onlays?
I think onlays are beautiful. Onlays are the most beautiful preparation you can do. Gold onlays. But remember that people can't afford gold onlays. That's why there's no BMWs in India. You heard that a patient came in to see TJS the other day and asked for a gold crown.
I saw his the lab work. It's amazing.
Was it?
He had sent on the group.
He did. Oh, I haven't seen it. I think a gold onlay is a wonderful preparation. An MOD gold onlay, when you take a when you take a bite wing X-ray, you can see under it, but you can't see under a crown. But to get good retention, it has to be very accurately made. Abby, have you seen my onlay preparation presentation?
Yes, sir.
Yeah. Anant, have you seen it?
Yes, sir.
Yeah. Okay. That's beautiful. It's one of the best restorations there is. Okay. Okay.
I have a question, sir. Sir, I have a question.
Where is it?
So, sir, I want to ask a question. So, question is, how should we decide which retraction cord should we use?
You need two sizes, one very thin and one less thin. And there will be situations where the wider one is not appropriate. but that's the decision you make when you do it, okay? I mainly use one size. And you know, the old little film cassettes that the old film used to come into, we would have two pots. One was at the length which was appropriate for molars and one for premolars. Okay. And the retraction cord liquid, which I think was aluminum sulfate, was already in there. Okay. Now, don't even dream of cutting retraction cord at the time you're doing the crown preparation. That is a ridiculous waste of time.
Can you repeat that once more?
If I were doing a crown preparation on a molar, the system would take out the crown and bridge drawer, take out the molar film cassette, take out at least two cords in clip tweezers, two clip tweezers. The cord would have the retraction liquid, the aluminum sulfate, already on it. And then when I needed it, she just passed it over to me.
You dip it in it. Do you dip it in the liquid then or before itself?
Which would you do if you were being really sensible?
I mean, in the sense like, is it okay dipping it in and keeping it like that? Or, okay, maybe I would do it before if there was a possibility. Yeah.
Right. You should not be dipping it in at the chair side.
Right. Okay.
That you don't have to have a dental degree to do that. Or spend 3 years doing a prosthodontic specialization to be dipping cord into liquid. That's ridiculous. So you need to get some little pots which you're going to put the cord in. Your assistant is going to cut the cord. And you need to work out how many centimeters. I think.
And these two film holders.
Sorry? What was that, Ashwin? Can we hear you, Ashwin? I think we used the width of a Post-it, probably for the premolars. You need to work out how many centimeters long you want the silk, you want the retraction cord to be for premolars and molars. Do you do that, Ananth?
Yes.
You do. And are they pre-cut?
Sorry, sir. I didn't get you, sir.
Are they pre-cut?
No, sir. I didn't understand what you asked before it, sir.
Is your retraction cord pre-cut?
No, sir.
You do it at the chair side?
I don't do the retraction much. I usually give a supragingival or equigingival.
You do what?
I don't usually give it subgingivally, sir. Times I do, but I do it chest side, sir. I used to do it chest side.
Anant, do me a favor, okay? If you've got a post-it there,
Yes, sir.
put down pre-cut retraction cord for molars and premolars.
Yes, sir.
One of them will be 5 centimeters.
Yes, sir.
Okay,
Yes, sir.
and you have to get a 2 little pots to put them in.
Yes, sir.
Okay, so you've got them ready.
Yes, sir.
And I would expect you to use it routinely, subgingivally.
Yes, sir.
Okay. What I'd love to do is to do a restorative course, which I've done in Delhi. And also to have you bring along some preparations, models of preparations you've done. Okay.
Yes.
Somebody that I taught arrived one day at my clinic and said, "Would you look at this model?" And I looked at it and I said, "Come into the treatment room. Here's a tapered diamond, flat end tapered diamond. Hold the diamond absolutely parallel and go round that tooth and improve the retention." Okay. Okay. We've lost Ashwin. Anant, can you call Ashwin and find out when he's coming back again?
Yes, sir.
Siley, Abby, can you see the presentation on the screen?
Yes.
Yes.
You can.
Yes, sir.
Right. Can you still see it?
Yes, sir.
Is it full screen?
It's not full screen, sir.
Okay. Is it now?
Yes, now it is.
Good. Okay. We've now lost Anant as well.
So let me call them.
Okay.
Sir, I tried calling him, sir, but his call is not going. I think he's on another call.
One thing I would like to do, because I'm not just interested in dentistry, I'm interested in many things. Do you know the word diction? Do you know diction?
No, sir.
Yes, sir.
Yes.
Yeah, diction is pronunciation. Okay.
Yes, sir.
And obviously my diction in English is pretty good. Okay. You may, because you speak Indian English, understand each other better than I understand you. That's because you're better tuned to listening to Indian people. I'm trying an experiment with Ashwin to see if his diction changes after I've done this experiment with him. And when I've done that, I'd like to do it with the rest of you. Okay? I think that the clearer you speak English, the better you get on. Well, I know you're not speaking English all the time, but if you're going to speak English, really clear English. You know how I have difficulty in understanding Eldo, you know. Have any of you had diction lessons at all? No, I did at
Not
one
really.
point. I did at one point. Okay. And I think it's a good thing for people to do. So you really understand them. So you couldn't get hold of Ashwin. Oh, he's coming back.
It's coming back.
Okay. Abby, I've gone over the how to make dentures with using the patient's dentures. Yeah. Okay. If a patient came in with no dentures, I would my heart would sink, because I know that I'm starting off with no information whatsoever, apart from the patient. Okay. So the reason for the difficulty is when making new dentures without using existing dentures is there are few existing landmarks compared with if you've got some dentures to look at. Okay. So the initial consultation appointment, the objectives is to listen to the patient and find out if they've worn dentures before, what problems they had. We need to assess and record the patient's wishes and objectives for their new dentures.
Ashwin's trying to join. He's waiting.
He's with us, I think. Thank you.
Yes, I am. Thank you. Thanks.
So the initial thing is to listen to the patient and record what they say. Okay. The better you got records of what they've actually said at the beginning, when you made the dentures, and you've given them a realistic assessment of how they're going to be, you can then go back. If they start arguing with you, you can say, oh, we discussed it when you first came, okay? I would think probably that complete denture patients are the most difficult post-operatively. If you do a filling, they very rarely complain about it. Might do a little bit, but dentures, they've always got a problem. So, Ashwin, we need to listen to the patient's observations. We need to record the patient's wishes and objectives. We need to examine the patient clinically and quote a fee. We need to ask them what they thought of the appearance of their dentures, their comfort, stability, and the fit of the dentures, how well they stayed in place, and how they got on eating. And as you know, this is very variable. You get somebody who's worn dentures for 30 years and they eat everything. Steak, everything. That's what they say. Obviously they don't, but that's what they say. Keep a list of the patient's observation, discuss with the patient which are likely to be solved by their new dentures. While I'm thinking about it, I always felt guilty when I made a set of full dentures because they were never fantastic. They were okay, but never fantastic. When I learned to put implants in and make overdentures, I had something to offer the patient, which was going to be a tremendous advance for them. And if they chose to have them, that was fine. If they chose not to have them, that's up to them. So I felt less guilty. You make overdentures, don't you, Siley?
Yes, but I haven't made many. Implant supported overdentures.
Yes. Do you use mini implants?
Not yet.
Okay, good. I would get to know an implant as a system and get them ready to use because I think they're terrific for dentures. Okay. And a question which Eldo has come up with as well is if you put in a whole lot of implants in a patient who's got no teeth and you put in a fixed restoration, what happens when they get to the stage where they're manually not very good at looking after themselves when they're old? And the staff are not very good at cleaning their teeth for them. So if they've got an overdenture, it's much better and much easier. So you must give them a realistic explanation of their future dentures. They might have 5 things that they want. And you could say, well, these 3 we can do definitely. The other ones, that's going to be difficult. So if their expectations are unrealistic, they may be disappointed. Also, you want to be really looking at their psychology. There was one patient came to me and he said his previous dentist was absolutely wonderful. And he was a talker, and I didn't suspect that he had psychological problems. And I delivered the dentures to him, and he was very dissatisfied. So I had him in. I previously signed a check for the amount that he'd paid me. And I took the dentures and I said, here's your money back. So you haven't lost anything apart from time. And he left. Okay. If he'd said to me, oh, no, they're quite good, really, I would have said, okay, I'll tear up the check. So you need to really assess the patient's behavior and see if there's any aspects of their psychology that, oh, you'd be glad to know, Ashwin, that I had 2 patients in about the same week, and I gave them a discount. And they were complete denture patients, and they complained and complained. If I'd only known and charged them an extra 25%.
Here's something I found on the web. According to Cambridge.org, the employee contribution.
Just be careful about giving people discounts, particularly for complete dentures.
Yeah.
If the patient agrees to treatment, then you start measuring the vertical dimension. Okay. The vertical dimension is changeable from a day to day, month to month. It's not, if you take a vertical dimension on somebody once a month for 6 months, you find it'd be different every time. It's not an easy thing. It's the most difficult thing in dentistry. Decide on the desired closed vertical dimension for the new dentures. Now, the principles of good appearance, this I consider is somebody that's got really good appearance. And these are the characteristics. The center line has to be straight. There was one patient that I was treating, a very, very nice lady. And when I came to check her dentures, which she had already, I took the floss and I put it, I put it down the center of the face. And a central incisor, one of the central incisors was right in the front. So the center line was shifted off to one side. And she'd had the dentures for about 20 years. So the center line needs to be straight. The incisors need to be straight. The lateral incisors, I would turn them a little bit. Unless you're an American, unless it's an American patient, because they want to look ridiculous and look perfect. So they're turning those a little bit helps. The canines need to be pointing inwards like this. And looking at the side, the teeth need to be disappearing away like that. And the same the other side. So when you check the try-in, you need to be looking at that. Now, these ones here, the central incisors are correct. One lateral incisor a little bit turned, the other one could be turned a bit more as well. But you see these are sticking out just a little bit. All right, if they were turned in a little bit more, that would have been better. It's not bad. You notice that on the patient's upper right, the lateral, the molar is sticking out a little bit. If the cheek teeth stick out a bit, the patient looks as if they've got an enormous mouth of teeth. Okay.
I think
Now-
the previous case, the lower midline is not okay, but it's, I mean, it doesn't make a much, not this one, the other one. No, just the previous slide, the last denture that you showed, the last denture.
There was only one denture.
No, not one, not this one. The other one, another slide.
Um,
The upper midline is coinciding onto an incisor. I mean, on the center of an incisor. Not this one.
okay, now let me.
No, my question was, I mean, does it really matter? The lower, even if the lower midline doesn't coincide, the upper midline, of course, makes a lot of difference with the aesthetics. But
Okay.
the lower midline, is it really relevant?
Okay, Ananth,
Yes, sir.
can you count to 10?
Yes, sir.
No, I mean, I know you can, but count to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So you notice he shows his upper teeth. Okay. And a little bit of your lower teeth. This is something that would be helpful if you check this with the patient, if they've got teeth. If they haven't got teeth, you can still get them to count to 10. Abby, count to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay. Now, Ashwin, how important is the lower center line for Abby?
I was trying to maximize the screen, so I couldn't see it. So,
Well, look at us.
Very
Look at
important for me.
the lower
My
center
lower
line.
teeth are with. Yeah. See, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Yes. You, Sally, talk like a man. With respect, men tend to talk with their lower lip down. I think actually you probably do both, Sally. So you get away with it. Okay. I don't know the statistics, but with natural teeth, you can actually find out how often center lines are wrong. Studies have been done on that. I think with complete dentures, try and get everything right. With natural teeth, that's a little bit more difficult. But I mean, it's the fact you're looking, which is the important thing. I mean, how many of you look at the buccal contour of the teeth in a case like this?
I do so.
Yeah. Okay. Now, then you look at the freeway space from the front and their vertical dimension. So you look at this person here, and I'm a little suspicious this patient's overclosed a bit. Okay. Here he looks a bit overclosed. He's not actually sitting there completely relaxed. He hasn't let his jaw go loose. So we need to know the resting vertical dimension, work out the freeway space, and I would repeat the vertical dimension measurement 6 times and take an average. Take away 3 or 4 millimeters and record what I think the ideal measurement should be. With this patient, as you'll see, I had to have the dentures reset up at least twice, because when I did the try-in, he was still overclosed. And it wasn't until I'd done it 3 times that we got the right freeway space. So you sit the patient up, take away the headrest. So the head mustn't be supported. You then ask the patient to look straight ahead and ask them to say Emma or Sonal or whatever words you use. What do you use, Abby?
Sir, I say, what do I say? So I say Shiva, or I say sometimes I say samosa.
Samosa.
Samosa, yes.
That might distract them a little bit if they're hungry. You've already distracted me. I love samosa. Okay.
I like samosa too.
Me too.
Meat or vegetable?
Have you
Sally?
tried keema samosa? Have you
There
ever
is-
tried
Yes,
keema
yes.
samosa?
Yeah, I love keema.
Yeah.
Anyway, so you get them to say something, and I say, let your jaw go loose. Okay. Or you ask the patient to lick their lips and let their jaw go loose. Some patients have got zero control over themselves. Very difficult. You repeat it 6 times and then write it down and take the average. How many of you have got a Willis spike gauge now?
I got.
You got one, Ashwin?
Yes.
Good.
So where do you get it? Where do you get to buy it?
I got it online, Anand. I think I got it from Dental Card. No, not Dental Card. Pink and blue.
Oh, okay.
1,000 something, 1,100 or something.
Oh, okay.
Alexa, what is 1,200 rupees in pounds?
1,200 Indian rupees
Ten-
is about
10
£12 and 2 pence.
In England, that would be the same as a pint of beer. Okay. But if we were buying it in this country, it'd be a lot more than that. Now, Ashwin, when you use this, you hold it up against the nasion. And then you raise the lower part to the chin. And you need to be watching the patient because they may close.
Sorry. There's a mistake. I didn't get this one. I got what is the other gauge? So what is the name of the other gauge?
Boli.
Bowling gauge. Okay.
Bowling gauge. This I couldn't find. So I
This
couldn't
one,
find
sir,
it.
I also searched. It was not available.
Yeah,
in
it was
any of
not
the
available.
Indian websites. Only in one Chinese website I saw this, but I couldn't trust that site, so I didn't order.
Alibaba.
Yes.
Why couldn't
It
you
was
trust
not
the site?
available. Because you can't expect the delivery date. Sometimes it won't even be transported and your money would probably go.
Yeah, I have lost money on such a site.
How many of you have contacts in the United States or in England?
We know Dr. Stuart from England.
Exactly. Okay. So
Stuart, one of my friend is in UK just now. He
right.
is there for 2 weeks.
Okay. We can you speak to her and say, would she mind taking some back with her?
Yeah, I'll talk to her right away after this session.
Okay, I need to know on Monday and I'll order them and have them sent to where she is.
Okay.
Okay. You see, this is how you solve problems. You know, I have a wonderful person who works for me now. She's just lovely. She's worked for me for over 20 years. But I know that if a problem arises, I'm going to have at least 6 ways of solving that problem. She has 2. You know, she can't unscrew something. So what do? You get a spanner out of the drawer and you put the spanner on, you do it. But she wouldn't think of that, you know. Mind you, she's far better than I am at sorting out the accounts and paying bills and things. So she has talents that I don't have, okay? Okay, Sadi, so let me know. And I'll
Yes,
find out
right away.
Okay. They're probably 3 lakhs each, okay? I'm sorry, I can't.
Seeing Ashwin's expression.
Say it again.
Yeah, the same expression that you're seeing now.
I said I missed seeing Ashwin's expression when you said 3 lakhs.
Yes, it would have been even more interesting to see Eldo's. I feel a bit guilty because, you know, I call Eldo a CB. Cheap bastard. When he was over here, we went up shopping and I bought a bottle of gin, a bottle of whiskey, and some food, and he paid for it all. And when we went to stay in a hotel, he paid for my hotel bill. So he wasn't a CB on that occasion. Okay. Right. I'll on Monday morning, apart from anything else, when I got off the plane and I was at the checkout, you know, the passport control, I'd lost 2 telephones and my other passport. So I've had challenges since I've been back. That's why I'm not using
What happened then?
I don't know.
How, sir?
I'm sure I got on the plane with them, but when I got off, I hadn't got them. And it was after a night's sleep on the plane, you know. Anyway, once you've got your Willis bite gauges, we need you to, we need to go over these slides. Okay. And Ashwin, don't use your Bode gauge, okay?
Okay.
Okay, so this is how you use the Willis bite gauge, which you don't have. Then you check the ridges. If you have a patient who's got complete dentures and you're going to make a new set, do you ever put the denture in and then put your finger right at the back to see if it's underextended?
Can you say that again? Repeat that, please.
Abby, would you tell him what I said?
He said that when you have a patient with the complete denture, have you ever checked at the back of the ridge whether it is underextended or not?
Using a finger.
Using a finger.
Yeah.
Okay. Checking the ridge if it's underextended, or you mean the denture?
The denture, sir.
Okay.
But it's quite
How can
difficult.
the ridge be underextended?
How many, Ashwin, how many patients have you had who had an underextended ridge?
No, please.
You know, that's my question. That's why I asked her to repeat.
Okay, this is a routine. You've got the dentures in place and you run your finger holding the denture still and you go back behind the maxillary tuberosity to see if it's underextended. This is where you lose retention.
Many
Okay.
times I've seen that. Yeah. You know, that region is usually ignored. Yeah.
Yes. Now, when I first came to England, and I was making some complete dentures, the technician routinely would trim the margin of the denture to what they thought should be right, as opposed to leaving the margin, polishing it, because that's what the zinc oxide Nugenol had reproduced, the correct periphery. Okay. So you check back here for overextension. You also check for denture
Many
sores.
times, even when we do it, we make an impression, and if we don't bead and box it, you know, bead and box the impression, again the margins are gone. But with, you know, I usually do beading and boxing for all my impressions. But what's the point? We don't fabricate the dentures in the clinic. So we give it off to the lab. They again trim off the borders and give it back to us.
Yes.
You know?
We'll come to this, okay, because there's no point in taking really good impressions if they're going to determine the periphery. You need to check for denture sores, and with this, in this situation here, I'd mix up some zinc oxide and eugenol, put a drop of water with it, put it in the denture, put the denture in place, and have them close gently on a cotton roll, both sides. Wait till it sets and take it out and adjust it. This is the best way of finding out where it's overextended. There are other pastes that don't set, which aren't as good. And I don't think you can use silicone. I don't think, but I've not tried it. So you have to let this you have to let this heal before you take the impressions. Now, the initial clinical appointment, which is your second appointment, and at the beginning of the second appointment, they pay half the fee. What do you do, Abby?
They don't pay that way. So what I do is I take half initially, not half actually, quarter initially, and then quarter in every sitting. That's how.
That's not a problem. That's okay. Okay. So you're not getting to the end of the appointment. You give them the dentures and haven't paid anything. Otherwise, they say, I'll come back next week, which means never. Okay. So on the first clinical appointment, which is your second appointment after your consultation, you then check the vertical dimension. That's the first thing you do, to see if it's the same as what you had before. Now, I'm suggesting you take a hinge record, wax record, you make them out of a sausage of wax, okay? And I'll show you why in a minute. You take the initial and alternate impressions using anatomical impression trays, not dentate trays, anatomical ones. And you need several sizes. Yeah, you can get these transform ones. Okay. This is probably the cheapest way. And you can reuse these. And they come in 3 different sizes. So you then take your impressions and then you take a hinge record, fingers on the lower jaw, thumbs on the chin, and you move you have the patient, you open and close the patient. If you can't move them, you ask them to open and close it and open and close. So you get a feel for how they close in the hinge position. You don't use this method. Were you taught that method at dental school, Anand?
Yes, sir.
So was I.
Yes, sir.
So was I. But I was taught that in 1963. Okay. Nowadays, this is not the modern way of doing it. You do not know whether the patient's in the hinge position or not. But you can, using the Dawson by manual manipulation, you do know. Okay, now, so we then take some wax like this and we put it onto the lower jaw. And we close the patient together in the hinge position to the vertical dimension. Okay. So we've got a rough bite rim, upper and lower together. We then check the center line, and has anybody done this recently?
Yes, sir. I'm in the process of doing it. Yes.
You are, okay. So you hold it with your finger or thumb on the top of the head, and then you hold it down without touching the face, and you get an idea of what the center line should be. So you hold the floss or tape with both hands, rest the finger on the top of the head, hold the floss or tape vertically, not touching the patient's face. Then you line up to the center of the face, an average. So you're looking at these features here. They're usually not in line. So you then mark the wax block. You then choose the shape of the teeth with the patient. If they've got dentures, you ask them what they think of the shape of their teeth is, and you, if they want them bigger or smaller or shorter or longer, you can then see what they think. Do any of you have any denture teeth in the clinic?
Yes.
You do. Abby?
Yes, I do have. Yes.
Yeah, okay, so you can show the patient some teeth. Okay. Now, in the laboratory stage, you pour the impressions, you hand mount the lower model, you mount the upper model using the wax rim. And then you make an acrylic or vacuum formed base plates. So you've mounted the models like this. You also, draw the extent of the special trays.
Sir, I have a question, sir. So you have taken the modeling wax impressions, but how the modeling wax is sticking on the jaw, sir? I mean, while you are taking the jaw relation, and without any special tray, like how are they sticking on the jaw, sir?
Skill.
Okay.
Okay. It's one large roll. It's one large roll of wax. Okay. You'll see the logic of this as we go along. Now, you then.
So, are the rims separate, sir, or is it separate rims or just a single block of wax?
Single block. Single block.
Okay.
Just 1 second. That's a single block.
Yes, sir.
Okay. So you then draw the periphery and how far back you want the tray to go to the fovea centralis. Okay. So this is for the lower, the extent of the lower. And you're going to take the tray up 1/3 up the retromolar pad. Now then, oh, on that wax block, just 1 second. Let me just go back a minute. When you've done this, and you got it at the right vertical dimension, you then draw a line where you want the incisal edge to be. You all got that?
Yes.
So the upper incisal edge. So you then take these calipers like this and you make a little hole in the model here, and then you open it to that line. The technician does this. So they've made a bite block which fits onto the suck down special tray. And you see the bite block is too big. So they then trim the bite block back to that height. Okay. Now, you have bite blocks made, don't you? Do you have bite blocks made? When you're making complete
Sometimes.
dentures, you have bite rims made.
Yes.
Okay. And what height is the bite block?
23 mm.
So, yes, as anteriorly 22, posteriorly 18, upper and lower it's 18 and 12. 18 at the front and 12 at the back, if I'm not wrong. Yes.
The height
12.
of the retromolar pad.
From where? From where?
From the this canine eminence to anteriorly from the canine eminence, and at the back it is at what level?
You're talking about a
The-
vertical. You're talking about a vertical.
Vertical, sir. Yes. Anteriorly it is from the canine eminence. Yes.
So it's got nothing to do with the lip height.
No.
Okay.
corner
You
of
see-
the mouth.
Sorry.
That will be with the corner of the mouth.
But the corner of the mouth, how is that recorded?
So what I do is I underline like the way you did it in the last slide, last to last slide. So I
Okay.
underline.
So you're having a bite block come back.
Mhm.
That is like this. Right? Your bite block is like this. and and you then cut it back.
Yes, this is how
Okay.
we do.
Right. So with this technique, you see it comes back very close to what you wanted. At the previous
Yes.
appointment, you drew on that initial wax block the height you wanted it to be. The incised ledge level by looking at the lip and deciding what level you wanted. So this bite block comes back to you already pretty close, as opposed to coming back like this. And I prefer to have a bite block which is reasonably correct. Okay. So the new wax rim is trimmed to the planned incisal level. And the posterior height is halfway up the retromolar pad. It's not a measurement like you were talking about, Abby. Okay. Because we're dealing with this particular patient. And patients are all different sizes. So we've now got bite blocks which are made on the second impression bite blocks. Okay. Now, do you have second impression trays and separate bite blocks? Is that what you normally have, Anand?
Yes, sir. Yes. Yes, sir.
Okay, right. So the second clinical appointment, we're going to take the final impressions and the records. We're going to check the vertical dimension again. We're going to take the second impressions in those bite blocks. We're then going to take a hinge record. Just 1 second. So we're going to take second impressions, and they have a little thickness to them. Right, you're going to have the zinc oxide Nusion in there. So you're going to need to adjust the height, the incised ledge levels a little. Then you take the hinge record. You check the vertical dimension at this stage, and you need to adjust it to your desired resting vertical dimension, closed vertical dimension. The bite blocks are going to have the zinc oxide Nusion line, so they may need a trimming a little bit. Now, these bite blocks, you firstly check the extension, make sure they're not overextended. and you trim the back as necessary. Then you add green stick. Okay. Now it's good to have a tile, and you put some Vaseline on it. And when you put some green stick around the denture, you can then put it on the Vaseline tile and it doesn't stick to anything. Okay. So you put the green stick on and you let it cool a little bit, and then you put it in the patient's mouth and you muscle mold. And then you do the front and then the other side. You then have to think about the posterior extension, which may be a little short. So you add some on the back, and then you add some on where the soft part of the palate is, either side of the center line. This acts as your post-dam. You either do this like this, or you scrape the model instead. This is more accurate because it's going to flow where the soft part is. Scraping the model is just by guesswork. You then take your zinc oxide usual impression and then you do the lower. So now you've got upper and lower impressions. Now, are these going to stay in place better than the bite blocks you're using at the moment?
These.
Much better. Okay. You could almost imagine these going in and just sticking in place. Whereas the bite blocks you're having made, what is the base plate made of?
Shellac resin.
How accurate is that? How good is the retention? Before I did this technique, I would have used shellac. And this is why I hated wax rims like that, made like that. Because it wouldn't stay in place when I was wanting to take vertical dimensions and things. So now, when you put these in, they stay in place. And now I would check the vertical dimension and maybe have to trim these back a bit. Then I would roughen the lower. Okay. Because I'm going to take a zinc oxide Nugenol hinge record. In the upper, I would leave them smooth, and I'd put, do you see there's some grooves in there in the upper?
Yes.
So I'm going to check the incisor ledge level now. I'm going to mark the center line. I'm going to mark the center line on the wax rim in the upper, like this. I'm then going to take a face bow Only because it's so much easier to mount the upper model. Now I take the face bow at this stage before I've taken the hinge record. If you take the hinge record and then you take the face bow, it can damage the record, the hinge record. So I take a face bow. I then check to see how loose his jaw is. And then I Vaseline the upper, put the zinc oxide neutral on, and close the patient gently into it. This is going to have a thickness. So when these models are mounted, you have to then take the zinc oxide neutral off and close the articulator a little bit.
I have a doubt.
Yeah.
Each time this is inserted, your secondary impression usually would have some, it can break off at here and there, especially the borders. Now, how do we avoid that?
You get me to do it for you.
It's a
It
fact.
doesn't
I
happen.
mean,
It doesn't happen. Okay, you're doing it delicately and carefully. It does not happen.
okay.
If it breaks off, it's because you didn't have enough support from your green stick.
Hmm.
By the way, just 1 second. Once you've done the muscle molding, you may consider taking 1 millimeter to 2 millimeters off the green stick to make more room for the zinc oxide neutral. But
Yes.
if it's supported correctly, just 1 second. I don't think that any of this would break off if you're doing it gently. Okay.
Mhm.
Now, can you imagine taking your hinge record with those bite blocks, with your second impressions inside, and the zinc oxide neutral on the lower? Can you imagine how those blocks stay in place? Now imagine you doing it with your shellac blocks.
No, I don't use shellac. I use acrylic.
Okay, that's better. That's better. Okay.
Shellac can fracture, can break off.
Yes. Yes. I'm glad you mentioned that. That's what I'd do if I wasn't doing this.
Yeah.
Also, Ashwin, there is an inaccuracy in doing what you're talking about. When you have these models poured up, what you're doing is you're taking your second impressions in special trays, you're having the models poured up, and then you're putting your shellac, sorry, your acrylic base plates with the wax rims on onto that model.
Yes.
That's not going to fit as accurately onto that model because the acrylic base plate you've had made was on a different model.
I didn't understand. What is it?
You're going to have your second impressions in special trays.
Yes.
And those second impressions are going to be poured up.
Yes.
You're then, to mount the models, you're going to put the bite blocks with their acrylic base plates onto those models.
Yeah, that's right.
They're not going to fit exactly.
Why not?
Because your initial impression was taken with alginate and your second impression is taken with silicone or zinc oxide neusional. The displacement, is going to be different.
The displacement is going to be different. But anyway, it's not contacting the okay. I understand what you're trying to say. Okay.
But you see here we've got first impressions. So we've got the second impressions. We've got the bite blocks which fit beautifully, and we've got we've taken the face bow to mount the upper, and we have got the hinge record. So we then need to double check so we know this is probably going to be greater than the desired vertical dimension because of the zinc oxide neusional on there. Is that okay with you, Ashwin?
No, I mean, it's okay, but I'm only worried about the practicality because
So what is the need of putting sorry, I'm so sorry for interrupting, sir, but I just had a question. What is the need of putting this temporary cement in between, sir, for recording hinge position? You can record it in other way around also without a temporary cement.
This is zinc oxide neusional impression material.
Sorry, zinc oxide neusional material. Yes. What is the need of it?
What else are you going to use?
So just like that, can we not record the?
How do you record? You're either going to use zinc oxide neusional impression material, or you're going to use a wax wafer.
Okay.
Yeah, Abhi is asking. I think the normal sealing method, is it?
Yes, sir. Yes, sir. The same way.
Yeah, that is not.
What we do is we take the two occlusal rims, and then we take a hinge position record, and then we just seal it.
Sorry, how do you take the hinge position record?
So just like the way you're doing it.
Like, how do you relate the upper and lower blocks together?
Okay, so Stuart, what we used to do it in college is we establish the right vertical dimension and ask the patient to swallow and bite, and then place Lacron scour, heat the Lacron scour and make two markings and seal the rims and take it out. So that's what she's saying. Why not do it?
So you're taking a hot wax knife, which you put into a Bunsen burner, and you're retracting the cheek and sticking that into the patient's mouth?
No, so just sealing the occlusal rims at the
How do you seal it? You have to heat the wax, right? How do
Yes.
you seal it?
with the with
Yeah.
With-
I mean, that's what Jesus is asking. Yes. Yes. Sealer.
With a
That's
wax
right.
knife, with a wax knife.
Yes.
yes, sir.
Yes.
So you're going to put a hot wax knife into the patient's mouth.
Yes, sir, that's what we do.
Okay, I'm sure
Anand,
you
are muted.
Yeah, remember the amount of crap you learned at dental school, okay? Now, which is better? If you put the zinc oxide usual on the lower and then you close the patient gently into the bite blocks, you've got an accurate hinge record then.
Yeah, Abby. So when you, I mean, that's what we all used to do it. So when you heat it, there is a possibility of the wax rims being displaced when you take it out. Okay, and you won't know it. Probably there would be a mild shift and you won't know it. But if you place a zinc oxide, the impression paste, or like how we used to place, pour a thin layer of dye stone in between. So what happens is once it gets set, and just in case if it gets displaced, you're completely sure that has happened. Whereas in the case of wax rim, even if there is a mild displacement, you're probably not going to, so it's accuracy. That's the difference here. And accuracy, and patients may not get burned also when you do it.
Thank you, Ashwin. Now, if you're not using the zinc oxide Nugenol, you're going to have to make sure your upper and lower wax rims are fitting together accurately. If there's a bit of a gap somewhere, how do you know that? Do you see what I mean? This is accurate. You see, it's another example of you see what you know. All right. If you do this, you'd think, wow, that really is accurate. How could I possibly have done it the other way? Okay. Now, say, for example, the height using the Willis bite gauge, which you'll be using in 3 weeks' time, is if you wanted it to be 70 and it's 73 with the record in there. When the models are mounted, you take the lower bite block out and you close the articulator 3 millimeters. Are you okay on that, Ashwin?
Yeah, I mean, I was just, I'm sure that Abby is not getting that. Yeah, it's like we never used to do it in college. So you place that's called an interocclusal record. What you say, the zinc oxide paste that
Yes.
Stuart was saying about keeping it in between the two rims. You got that, Abby? You got that, right?
Yes, sir. Yes, sir.
Yeah. So once you place something, now you're placing a paste between the two rims, already established heights. Rims are already established, but you're placing something in between to, to get those two rims locked at a perfect position. Now what happens is it requires certain amount of thickness. So the dimension is going to again change. You understand? You're placing some paste in between the two rims. So the height of the whole thing, once the impression paste sets, is going to again change. Now you're going to place the lower rim and you're going to articulate, right? So once you articulate it, the height is going to again further change and alter. So instead of that, you remove the occlusal, lower occlusal rim, and you adjust the height of the incisal rod by 3 millimeter. You reduce it by 3 millimeter. The thickness of the record was 3 meter. It was raised by 3 millimeter. So you reduce the incisal height, rod height by 3 millimeter, and then adjust the occlusal rim accordingly. You know, to that position. You remove the occlusal rim and then you articulate it.
Okay.
Hope you understood what I'm trying to say. So you compensate the thickness of the interocclusal record by adjusting the height of the incisor rod.
Fine. Okay, sir.
Yeah.
Now, what I suggest you do, I have to re-upload this presentation with 1 or 2 adjustments, which I've been thinking about. And what you do is you go through it thoroughly and you wait for your first victim and you look at it again and you give an extra amount of time for each of the appointments. And if you do it this way, you'll find that it's far more accurate. You see, this zinc oxide nusionol you can see here is accurate. The bite blocks you used before weren't necessarily fitting each other exactly. Now, you then draw on, before it goes to the laboratory, just 1 second.
I think we're running out of time.
Yeah, okay, just let me do something for a minute.
Anand, how many balanced occlusions you are required to do college?
Sir, I've not done much, sir. 2
Okay,
cases.
so you
in my
got this
group.
point, what was happening? You got this thing that we were discussing right
Yes,
now, right?
Yes, sir.
Yeah.
Can you see what I've written here? Do you see before sending to the laboratory? All right. You take a felt pen and you draw where you want the impression to be poured.
Cannot see your screen.
Cannot see
Okay.
the screen.
Okay. You see it now?
Yes.
Yes.
So you need a red felt pen. Blue if you want, but I think red. And you draw where you want the impression to be poured to. You don't leave it to the technician.
Mm-hmm.
If you don't do this, they can pour it however they want to and not necessarily have all that beautiful periphery on there. So the models must be poured to that line. And I used to pour those models like that. Okay.
One second, can you just go to the previous slide? Yeah. Now the line that you've drawn is okay. Now, so how do they maintain the width of the land area? I mean, You know, the land area, the land area. How do you maintain the width of the land area? I mean, how does a technician maintain the width of the land area if you give him like this?
When he pours
I can.
this, there must be
Sorry?
enough. There must be enough plaster on the outside of that red line.
So he does the beading and boxing, is it? The technician does it.
There's no beading and boxing.
Then how does
But then how do you take it out, sir? I mean, I think it might be
The
so
base
difficult.
supports it, the land area.
sorry? What does Sally say?
The base, they pour the base that supports the land area.
I don't know what you mean by land area.
So the width of this
You know the where the denture ends in this picture,
the red
from
line
there until the end of the cast,
cast,
that
yes,
horizontal width
the
is
horizontal line.
what we refer to land area.
What do you mean by land area? I'm not familiar with that term.
So when you're looking at this picture, where the denture is poured, where the red line is seen, a little bit of the red line, from there until the periphery of the, yes, from there until the end of the cast, yes, that part.
It must be wide enough so that when you remove the denture, you don't break the cast.
Yes. So how do we maintain that width when the technician pours? Now he's going to struggle building up that region if he doesn't.
No, he just does it. This has already been trimmed. Okay. When it's poured, it's bigger than this. It comes out. I mean, this is probably, say, almost 10 millimeters away from that red line, the periphery.
Yeah, it is. But I wonder how he did it. I mean, he's probably there is sufficient amount of width, but I'm just thinking how he must have done without beading it.
I would have poured these into a rubber mold.
Yeah, base former.
Yeah, and there would be excessive amount of plaster. If you want to bead it as well, you mean you bead it above that red line?
Yes.
Oh, you could do that if you want.
Yeah.
You could do that, okay? I didn't do that, but you could do that.
Okay. Yeah.
Okay. The main thing is that you can imagine at the moment that sulcus that you devised with the green stick and the zinc oxide nusional has been reproduced exactly.
Yes.
Okay. And you've determined it. You have to bear in mind that the same technician who's doing this for you also does dentures for very ignorant dentists. So he has to really concentrate that if you didn't draw that line for him, he might just do it like he normally does it. Apart from the fact that in crown and bridge work, in a small laboratory, who pours the impressions in crown and bridge work?
The dentist.
No, in a good little laboratory, a little laboratory. I'm not talking about den care.
The junior most guy.
Absolutely. Okay, the last person in the door, because the highly trained ceramic man or gold worker does not pour the impressions. Similarly, in a denture laboratory, the person who's experienced at waxing up dentures does not pour these impressions necessarily, unless it's a sort of a two-man lab. You see, because we poured all our own impressions, we trimmed the models, we mounted the models. There's no point at which the technician can make a mistake until he gets the final thing to do the job he has to do. Ashwin, can I thank you for not showing us your screen, you in the screen, because I haven't been able to see you yawn today.
Okay, we'll try to do that in future also.
What I suggest is that next time we go through this again and we go on with the next step.
Right.
Yes. Stuart is Scunthorpe close by. My friend will be in Scunthorpe till 30th and then in London and leave on the 3rd of December.
Your friend leaves on the 3rd.
From London. And she will be in London after 30th for those 2-3 days. Currently,
Okay.
she is in Scunthorpe. I don't know how.
Just 1 second.
And she said she can get a parcel.
She can get a parcel.
Yes.
Okay, if you send me
Yes.
send me the address.
Okay.
So if I get onto that on Monday, I'll get the company that sells them to send them directly to her.
So Monday will be 29th.
That's
Where would
right.
they be sending? They'll be sending it to London, right?
Yes. Okay. So send me the address. Okay.
Yeah, I'll ask for the London address.
So we need, at the moment, we need 1, 2, 3, 4 at least. Ashwin, can you do me a favor?
Yes.
Can you check and see if TJS and Eldo needs one? I think Eldo may have one.
I'll do that. Yeah.
Okay, and let me know.
Sure.
Okie doke. We'll see you next week.
Okay, sir. Thank you so
Thank you
Just,
so much.
Okay, good to be
Thank
back
you.
with you all. Cheers
Same
then.
here.
Yes, absolutely. Thank you.
yes.
Bye.
Yes. Bye. Bye.
Bye.
Bye.
Cheers, Anand.
Cheers.
Sally, Abby, Ashwin.